The fact that we have better and better data all the time, that all the spending is not buying us the results. There is an opportunity in there to look in a more critical way at what are the most powerful investments that we can make in the health of the people.
We have successes. The nation's health is better than it's ever been. Not for everybody, but overall, we have improved things. Let's celebrate that. Point to some of the deficiencies, especially when you consider the expenses and other countries. But let's celebrate those achievements and say, we did it then, we can do it again.
Moving Upstream, Working Together is a co-production of the Blue Cross and Blue Shield of Minnesota Foundation, looking beyond healthcare today for ideas that create healthier communities tomorrow, and TPT's Minnesota channel. This program was recorded on November 13, 2006 in Bloomington, Minnesota, and is comprised of portions of a full-day health forum.
My name is Jan Malcolm, and I've been previously introduced, and I'm just very happy to be with you this afternoon. I am currently the Chief Executive Officer of the Courage Center, and know many of you from prior parts of my health policy career. I consider myself one of the luckiest people in health policy in Minnesota. I've worked for a number of the most wonderful health organizations in our community, and I had the great privilege to serve as the state's Commissioner of Health for 4 years. During which time I think we made some important progress on issues of reframing the health care conversation in our state to be more a conversation about the health status of our state and the gaps in health status in our state. And I'm very proud of the work that this community has embraced and continues to do along those important issues of health for all Minnesotans. My task here is to just talk for a couple of minutes, although with all the wonderful presentations that have come before, there's not a whole lot new I have to say, but that never stops me from commenting anyway. I'll maybe tell a couple of stories along the way of some of the highlights and the lowlights of kind of public sector involvement in these issues as I've had a chance to experience them. And then I'm going to turn it over to continued conversation with our faculty. Before I say one more word, though, I really must once again thank the Blue Cross and Blue Shield Foundation for putting together this really remarkable resource for our community. The faculty here today, the resource materials, this is extraordinary. I think those of you who are working currently in this field know that we have heard today from some of the very top practitioners in the most cutting-edge issues in public health research, and I think that's just a really remarkable gift to the community. So thank you to the foundation. And it will be up to all of us to figure out how we use this information now and how we continue to build on this conversation going forward. That's, of course, always our challenge. How do we share the enthusiasm for these issues that exist in this room with the people who aren't in this room? The public policymakers, the private sector decision makers, the people who can really influence change on the kind of dimensions we've been talking about, they need to hear some of the things that we've been hearing all day and hear it in clear, compelling, and consistent terms from all of us. So if this is indeed the choir, one of my main messages is this choir's got to sing a little louder. And we have to sing with a little more passion and a little more consistency and persistence in our message. We are passionate advocates for the health of the public, but we need to just tune it up a notch or two. So let me just comment on a couple of things. I think the question of what's it going to take to produce healthier communities, the basic answer is it's going to take changing the conversation. It's going to take having the conversation we've just been having all morning as the conversation about how to reform the healthcare system in our state and in our country. And this isn't usually what we talk about. I mean, the stunning thing to me, contrasting today's conversation with most health policy conversations or most places in our nation or our state where people are talking about how are we going to improve the healthcare system, they don't talk about the social and economic determinants of health. They talk about these three things. This, what's on the screen is the all-familiar three-legged stool of health policy. Nobody gets to go anywhere without saying the question is, how are we going to balance healthcare access, healthcare quality, and cost effectiveness? Those are the three things that matter. What's not on this slide? What difference does it make? How much health status is any of this activity actually buying us? So my premise is we're talking about the wrong thing, or we're at least talking about an incomplete thing, unless we are talking about how much health we are buying, especially for our collectively invested resources. That is a fundamentally different way of talking about this problem, and I think therein lies some of the opportunity, as well as some of the challenge, to be sure. What do we usually talk about? We usually talk about these things. Who's paying? And what's wrong about that balance? Who should pay more? Who should pay less? Where's the money going? Does somebody have too much? Where can we cut? Recently, we're starting to talk about other things, including how can we improve quality across the board? That's good, but it still isn't getting at this more fundamental question of how much health status we're actually buying for the money. And unfortunately, if all we do is focus on the three-legged stool, we've already lost the battle. We've already lost the major opportunities to intervene in the things that are producing the need for the health spending in the first place. The good news is, if we would change this discussion, broaden the dialogue to include the kinds of things we've been talking about all day today, we could do a whole lot better. And the really good news is we could be doing a whole lot better for a whole lot less money. So I think there's an opportunity to join these conversations, to grab hold of the challenge of healthcare cost containment and begin to point out, not that these issues are a panacea for that, but that unless we start talking about the social and economic determinants of health, we will never make progress, meaningful progress, on either controlling the cost of health care or, more importantly, getting a commensurate gain in the health of the population for all that incredible resource we're investing in the system. I wish we would talk all the time about these kinds of statistics, and several of our presenters touched on them this morning, but none of us in this room, nobody in the health plans or the hospitals or the clinics, anywhere, should ever give a health policy speech without saying, oh, and by the way, we do not have the highest quality health system in the world. Let's just start debunking that myth right now. We need to get the public and our policymakers much more conversant with facts like these and much more outraged about facts like these. That we don't just spend a little bit more money than other countries, we spend half again as much as the nearest other industrialized country. Yet we rank way down the list on these very complex and admittedly complex multifactorial dimensions of how would one judge the overall quality of a health system. Since my day job is now a little bit different, I'm not as current on these statistics as I'm sure some of you are. But the fact that the World Health Organization ranks us in the low 30s overall with respect to the aggregated measures of health system performance, the fact that we're only number 25 on life expectancy, or 27 perhaps I saw today. This next one, to me, is the most damning of all, that our infant mortality comparative ranking has fallen in recent decades. Not that we haven't improved, we have, but that whereas we used to rank about number 10 in the world, around 1960, if I recall, I think we just heard this morning that we're number 28 in the world on infant mortality, on a measure as basic as that. In the last 40 years, 45 years of explosion in capacity on the intervention side, in terms of medical care capacity to deal with problems after they've already happened. The thing that just amazes me about this is that we can let our policymakers and let ourselves off the hook so easily when it comes to statistics like these, and that we're just quick to dismiss these as somehow irrelevant to the discussion about how are we going to build a better health system. The fact that we only rank number 1 in the world in life expectancy at age 80 is rather telling. That is the place where all of our high-tech medical interventions can help us the most statistically. Of course, there's still not very good measures about the quality of that life or the degree to which people are making well-informed decisions about medical care consumption at that point. But be that as it may, we do rank number 1 in the world on something. The public health perspective, of course, is that this whole conversation needs to be about maximizing population health at a manageable cost, and understanding that if we spend too much money on medical care interventions, to the exclusion or to the detriment of some of the other investments that also produce health, we're not doing the right thing in terms of population health status. It's also, I think, a very good thing that we're now, as we're back into talking about health system reform and healthcare cost containment, we're so much more aware than we used to be that the problem and the opportunity is chronic conditions, not the kind of acute care conditions that we've built our whole healthcare system around. And the chronic conditions are the greater threat to the health of the population and certainly the major consumer of the healthcare budget. And again, the good news, that almost all of those chronic conditions can be impacted. Some perhaps prevented altogether, but almost all of them ameliorated, lessened in their severity, if not their incidence, by a more robust approach to prevention. And prevention just simply has to be more central in our funding and in our policy decisions. And we've got to better line up what we do with what we say. And we've talked about this pie chart earlier today. This is the fairly well-known CDC picture of the relative impact of these health determinants on the health of populations, the fact that access to health care as an explanation for the difference in health status between populations. Access to health care is actually the smallest part of the pie compared to behavior and genetics, and then the very rich and rapidly evolving discussion and awareness around social and economic and environmental conditions and all of the interactions among all of these things, which of course make it not such a tidy picture at all. But the big part of the story is this one about the absolute imbalance of the investments, and we've talked about that already today as well, so this isn't new. The fact that if health care interventions are the minority of the impact, they are overwhelmingly the majority of the investment strategy for the nation. And this is a bit counterintuitive to people to think that it could be this badly balanced, or to suggest then, well, so what do we do about it? And I'll come back to that in just a moment. How do we get more health out of the dollars? How do we take this picture and start to rebalance it? One thing I would suggest we might do is to better enlist the clinical community in the cause of understanding that unless we start looking at some of these other pie slices, unless we start investing in some of those other determinants of health, the health care system, be that the health plans or the hospitals or the docs or the nurses, the intervention side of the equation is going to continue to be set up for failure. We're going to continue to chase our tails if we don't begin to get more serious about also investing in those other determinants of health. That will just keep on banging on the healthcare system for its failure to produce better results. We're holding them up, essentially, as responsible for something that this pie chart seems to indicate is an unfair proposition. It's not as simple as saying, well, take the money out of the health expenditures piece of the pie and redirect it into other health determinants. That's part of the strategy, but how we're going to do that gets a little trickier. I do think we have to have a very, very big conversation in our community about how to get more value out of those medical care interventions. I think we need to be willing to embrace the questions of how do we set better priorities for health care spending on the intervention side of the investment. The quality improvement movement that's underway is really good news from our perspective in terms of trying to free up some of the dollars in the healthcare intervention slice that perhaps are not as big a bang for the buck as some of the social and economic determinants kinds of interventions. But we're naive if we think we're going to grow the whole pie another 50% in order to get enough money into the non-medical determinants. So finding ways to free up some of the healthcare spending through quality improvement is a real opportunity. We must put a higher priority on prevention. One way to start, I would suggest, would be to do something as basic as to figure out what we're spending on prevention. What share of the health budget is prevention spending today? It's rather ridiculous that we really can't put our hands around those numbers very well. We don't even have a good metric for how much are we spending. We know it's sort of approximately in these 95.5, 92.8 kinds of dimensions, But the fact that we don't have good metrics tells you something about our priorities. So let's, at the very least, set as a priority and as a policy goal that we develop the ability to track this stuff and measure it over time and have some intentionality about moving more of the investments into the prevention side. Yes, we need to have a greater focus on individual responsibility for health choices. That's all the buzz. Consumer-directed health care, personal responsibility for better choices. Certainly you look at that Determinants of Health slice and look at the significant impact of behaviors, and you have to say yes, but we have to also understand what our speakers all day today have been talking about, that it's the kinds of environmental and social forces that surround the individual choices that are going to make those choices either possible or not possible as a practical matter. And we've learned a whole lot from the tobacco movement about the success of environmental approaches to tobacco control in advertising restrictions, in smoking in public places, in tobacco tax policy. All of those things have taught us a tremendous amount about the importance of the environment in terms of influencing individual behavior. I used to just absolutely love the debates with the legislators, even 4 years ago when we were beginning to talk about childhood obesity. The legislature just couldn't get its brain around what they possibly could have to do with that in terms of what exists in the schools by way of curriculum or by way of nutrition policy in the schools or by way of where the schools are located and what the transportation policy is to get there. And the whole larger field of livable communities or healthy communities by design, which we've heard about today. This question of better balancing our health investments as other countries do and understanding that those other kinds of social policies, education, housing, transportation, community development, and income policies are health policies is, I think, what's so very encouraging about the international analysis and comparisons that are happening now, that we ought to embrace that and not just say whatever happens in the Netherlands or New Zealand or Germany or the United Kingdom is not relevant to us. We have to instead embrace that and say either implicitly or explicitly they seem to understand that some of those other determinants are health strategies and not just disconnected social policy strategies. So I think our challenge, given what we've been talking about all day, I haven't really said anything new here that others haven't said all day, but it does strike me that the challenge before us is to try to make the other healthcare reform conversation and this conversation merge. That we cannot afford to have the politicians or the private sector decision makers say, oh, that's all very interesting what you're talking about the impact of community design on obesity rates and so forth, but can we get back to the important stuff? Can we get back to talking about how we're going to insure more people or how we're going to pay for conformance with clinical guidelines and and I think I'm certainly not suggesting those things aren't important, but that these things, the social and environmental factors that influence health, are not afterthoughts. They have to be at the beginning, at the center, in every single health reform conversation we have. And we know that there's going to be a lot of pushback, and we've even engaged in some of the pushback here today in this discussion. We know how powerful the pushback will be from policymakers about focus. I started the morning today with probably for about the 200th time in my career being accused of wanting to boil the ocean. It's true. But and actually probably that's exactly the wrong analogy. We want the ocean to cool down a little bit, but this push from the legislature, from funding sources, from corporations that we all face about having to pick a focus, having to choose which one issue is the important one. On the one hand, we have to be, as several of you said, realistic, start someplace feasible, start where we can show an impact, but never to let go of the fact that this stuff is all connected, and it's just sort of a setup to say, okay, yeah, let's take on childhood immunization as the issue. in a vacuum, that we cannot allow the choices to be framed as either or. Perhaps in terms of timing, perhaps in terms of measurement, we can in fact be targeted and focus on what's feasible, but we really need to embrace the complexity, the connectedness, the holistic nature of the conversation. I was so glad I got to hear Winona LaDuke speak after lunch. That was just absolutely eloquent, and I can't imagine the legislature ever evaluating the impact of their decisions by what will happen 7 generations from now. I just found that to be so profoundly moving, and so right, as compared to what's going to be the impact in this biennial budget. And certainly if it doesn't happen in this governor's term, whoever it is, it doesn't count at all. But I have seen successes in agencies, whether at the state level or at local government level, beginning to work across boundaries, beginning to do budgeting in a different way, beginning to pool resources, beginning to credit the impact of public health strategies when you see a change in the human services budget or expenditures, or in the special education or corrections. And we as community stakeholders have to push for a different kind of accounting and stop saying that it's okay if the budgeters simply create their little silos between these social impact areas and doing the accounting in such short-term and highly artificial ways. We do have some massive challenges about communications, obviously. Changing the way we talk about these issues, having it not just sound like we're trying to boil the ocean, but that we're really interested in the ultimate impact analyses. We're interested in how do we actually get more collective impact for our collective investments. And if we're serious about that, and if we're serious about staying on top of some of the really exciting work that's starting to emerge, some of the frameworks you've heard about today, some of the international work that's going on, if we follow the evidence and we follow it far enough upstream, we can have a powerful impact. But it's going to take a whole lot more voices being dogged about the messages and about the need for cross-sectoral, not just work, but cross-sectoral financial accounting, budgeting, shared governance kinds of structures, so that we really start breaking these silos down. I could, as many of you know, go on and on and on about this, but I'm going to resist that temptation and now take a seat with the rest of the panel and open it up. I hope that our faculty members have questions for each other. And I very much hope that we've got some energy left in the room to ask questions about where in all of this very intellectually stimulating work we might begin to focus and to really marshal some broader community awareness.
Related to the point that Jan was making, the issues that it's been great to be part of this, all the cross-disciplinary work and thinking, and the magnitude of it is daunting. So partly in response to what Jan said at the end about trying to boil the ocean or freeze the ocean, what if we tried to focus on young children as a unifying concept that breaks through ideology and region, and it's sort of like, okay, we can work with focusing on these people. We can't blame them yet. There's all the politics aside, these are still people that really matter. And what if, as a next step to this day, there was some kind of a growing consensus that as a way of dealing with these various public health issues upstream, there was agreement to focus on a particular little subgroup, like, now granted, Ready for K is about kids birth to 5, so you can take this as a self-interested encouragement, but to get focus and to do something that's going to actually be different than what was the case before the day started. What do you think about focusing on a young or a particular group, like young children, and I'd just be interested in the panel's reactions to that idea, because I do think the danger at a session like this is it's so vast. I mean, it's fascinating and it's interesting, but once again, we've, in Minnesota style, admired the problem elegantly. What's going to be different for kids or anybody else in the state of Minnesota, and how can we make sure that part of what we come out of this with will change that reality? And I guess a final point, it would be so excellent if the healthcare community, the providers like Blue Cross Blue Shield, could have a concerted effort to do something together, whatever it is. I would advocate that it be something, as they have done with Blue Cross Blue Shield, to focus on young children. But wouldn't it be nice if the corporate power that's reflected in the healthcare community could be focused in such a way as to include cooperation on at least one issue that would move the needle? So I'd be interested in the reaction of whatever panelists you may have that wants to talk about it, of focusing in that manner.
Dr. Shetler.
Yeah, I'd like to just make a couple of brief comments in response to that. I think that there are a lot of arguments for doing that, but I'm always reminded of a statement that I heard at a meeting once where Peggy Shepard was present. I don't know how many of you know Peggy, but she's the executive director of West Harlem Environmental Action, I think, is the name of her group, We Act. And she said, when we were having a conversation about children's environmental health, she said, look, let's be clear, we don't love our children. You may love your children, but we don't love our children. And it was rather stunning to think about that, because if you look across a whole range of policies, there's good evidence to support what she said. If you think about the food we feed our children, if you think about the systems that we put in place to nurture our children and so forth, there's a lot of evidence that love is somewhat constrained and constricted. So I think that it's a very interesting idea that you've raised, and I think it would be interesting to start a public dialogue about the extent to which we love our children. And while I'm mentioning that, and I'd like to also follow up on your comments about future generations and what Winona had brought up. What's the extent that we really care at all about future generations? There's a lot of evidence that we don't. In fact, there are a lot of people in public policy decisions making positions who suggest we have no obligations whatever to future generations. But that would be an interesting public conversation, and we might think, for example, of appointing guardians for future generations or guardians for children 0 to 5 in policy decision-making bodies whose job it is, whose task it is to speak out for that group of people, just to see where that goes. Because I think there are a lot of hidden assumptions here that we would benefit from bringing out into the open.
Yeah, just to follow up on some of these comments and thoughts that we've been having, social determinants of health, environmental determinants of health, they're kind of act across the lifespan. And so I think that there's opportunities for everybody to benefit when you focus upstream on specific determinants of health. And to me, the focus, I think, needs to more be twofold. One is you need to identify, since there's such a wide variety of issues to work on, what is your community ready to work on? So it doesn't do any good to have a bunch of people sitting around in a room in the capital of a state or in the capital of a nation and trying to decide for communities what their most important issues are and what their priorities should be. So I think one community might want to make a focus on children. Another community might want to make a focus on working on the transition of the issues among young black men. So what is the issue of incarceration in their community and how to prevent that from happening? Another community might be very concerned about exposures to environmental toxins which affect all age groups. And I think to me, the key issue is not deciding for the community, but working with the communities to pick on the issues that they are ready to move on. If there's not readiness for action, nothing will happen even if the issue is framed in its most beautiful way.
Yeah, I think the overall point you were making about the tension between focus and the breadth of the issues that we're trying to look at is really important. Let's think back to the last time that health policy was really on the nation's agenda. That was the health insurance debate, right? Health insurance for all. I think the nation left that discussion basically feeling that this is too big. This is hopeless. We'll never get our arms around that. And so I think fundamentally what we need to do is to